Hello, I'm Jan Basile, and I'm speaking with Dr. Peter Jones about management of hyperlipidemia in the adult. As we know, statins are clearly beneficial. They're better than placebo, and more intensive treatment is better than less intensive treatment, especially in secondary prevention. So the question that we wrestle with in our practice is which of our primary prevention patients are at high enough risk to consider statin use for benefit? How do I determine in that waiting room of patients who have no events in their history which patient will most benefit from a statin?
That's a fabulous question, because most of us are worried about cost effectiveness of treatment. Although you'll read in articles that primary prevention usually isn't cost effective, but we treat patients one at a time, and the real challenge is to find out which patient we believe will get the most benefit and will have more benefit than harm. I think primary prevention rests with risk assessment, which we do with taking risk factor determinations, age of the patient. Certainly you can use the lipid values, but we use the Framingham risk score or the Reynolds risk score as ways to determine risk. I think in the new guidelines that'll come out, they will say that especially for women, if it's more than 6% or above 10-year risk of Framingham risk score, certainly with a Reynolds risk score, that would be a woman that would be in a intermediate risk, needs to be considered for preventative treatments, of which statin treatment would be one. In men, probably 10% or more, a 10-year risk would be a man who would be considered for primary prevention. I think C-reactive protein will be a non-lipid biomarker that will help with that risk assessment. The real cost-effective question in primary prevention is whether you do anything more than just biomarkers, whether you do clinical measurements of atherosclerosis like a carotid intermedial thickness, which is non-invasive, no radiation, done in the right hands, can look at the common carotid artery for thickness of the media, versus coronary calcium, which I think does have a little bit of ionizing radiation risk, but is probably not as good in detecting high-risk women of primary prevention, because coronary calcium lags in women and compared to men. So I would say that probably after the age of 45 years old, you need to be looking for both men and women who might be candidates for primary prevention. The older they get, that becomes a clear determinant. Men over 50, probably women over 60 should have a C-reactive protein done, along with looking at their lipid panel. Obviously, you're going to assess presence of metabolic syndrome, blood pressure, lipids, mix that all together and decide, along with Framingham risk score, whether you think that person deserves a long-term treatment with a statin to lower LDL cholesterol.
If a patient has a 2-year life expectancy, is there any age where you would no longer worry about lipids?
I think that's a great question. We do have data between age 65 and 80 that primary prevention does work in reducing their cardiovascular events with really no downside or harm. But and those are clinical trials, and patients who are 70, 75 years old who make it into a clinical trial make it because they can come to the visits, they're independent, and they're self-sufficient. So I think if you have a patient who's older, who has a reasonable future life expectancy, so you see the near term 5 years or more being something worth preventing and preserving quality of life, then I don't think age is an issue. But I think if you do have a relatively shortened quality of life window, probably primary prevention in an older person is probably not going to be something you do.
Okay. So I decided to use a statin in the patient, and they're tolerating it. I've got their LDL down 50%, and their LDL now is hovering around 70. They're doing well. And I asked myself, do I need to use another form of lipid-lowering therapy to benefit incremental risk, to further reduce their risk? And what's the evidence suggest on that?
Well, that's a great question, because our primary target's always LDL cholesterol, and probably will be even in the new guidelines. Although we may have co-targets of particle numbers like ApoB and non-HDL. But the incremental question is whether there's something else in the lipid parameters that are not optimally managed. And that would be, for instance, HDL, or maybe even triglyceride. So far, the data is not as strong as it is with statins on LDL lowering. We do have data that patients with insulin resistance, particularly type 2 diabetes, on a statin, whose LDL is about 70, do better and have incremental reduction in events if they also have high triglycerides and low HDL on that optimal statin treatment. If you add a fibrate like fenofibrate, you do get additional incremental benefit. If they're not diabetic with high triglycerides and low HDL, adding a fibrate on top of a statin does not seem to add any incremental benefit. Yeah. We've just got some evidence, going to be presented here very soon, about adding niacin on top of optimal statin treatment in high-risk patients who have low HDL. And in this case, an LDL of 70 on an optimal statin, adding niacin to try to increase their HDL apparently did not add incremental benefit. We need to see the paper a little bit more to understand whether there's some subgroups there that might benefit from niacin. But at least in the situation with optimal statin treatment, LDL at target, adding niacin did not seem to add any incremental benefit.
Interesting, yeah. Because physicians are reaching for additional drugs, trying to alter the lipid parameters in an effort to improve outcome. And we've been surprised.
Well, we've been surprised. I think targeting HDL may be surprising because it may not give us as much benefit as we think if LDL is low enough and particle numbers low enough. But that doesn't rule out the fact that niacin in and of itself lowers particle numbers. So we still use niacin to help us achieve LDL cholesterols of 70 or lower. So if you can't get to 70 or lower using statins or other drugs, niacin, I think, is a good option. So there is a place for it. It's just this clinical trial didn't look at that place. It was looking at it under a different set of circumstances.
Yeah, and the most recent thing, shifting to another area, is the concern with some of our anti-lipidemic drugs of the downside. So recently statins, and for a number of years we've known that nicotinic acid is associated with a greater risk of new onset diabetes.
Correct.
And you know, it's sort of analogous in hypertension to the thiazides be associated with new onset diabetes through some form of insulin resistance. How does the clinician reconcile new onset diabetes with statin use and nicotinic acid use?
Well, you know, it's probably the same thing with high-dose thiazide type diuretics. You know, the people who have underlying insulin resistance are more likely to have hypertension. They're more likely to have high triglycerides and low HDL. So the kind of patient that we tend to treat as high risk, you know, may be more likely to develop diabetes anyway. Whether the drug is helping them down that road a little bit or not is still an issue. But you're correct. In high-risk individuals, in a meta-analysis, statin use did increase the incidence of physician-diagnosed diabetes by about 10%. Niacin, a vitamin, has about the same tendency for new onset diabetes. But we have benefits that outweigh those risks. And many of these high-risk patients are probably going to develop diabetes anyway. But why would a statin increase that risk of diabetes? Well, there is no data that statins are insulin-resistant causing compounds. There is evidence that niacin does increase insulin resistance, so not surprising there. It's just not clear what statins are doing. But I think the number needed to treat for benefit from a statin is far better than the number needed to harm. It's actually about 5-fold better in the number needed to treat than the number needed to harm when it comes to diabetes. So I think most of us would maybe be a little bit more vigilant in our high-risk patients who are pre-diabetic or insulin resistant to see whether they develop diabetes once we initiate a statin. But I certainly wouldn't stop a statin if they do sort of cross that threshold and move on to diabetes.
Okay, very good. Well, thank you, Peter, and thank you all for joining us at the annual meeting of the Southern Medical Association.